So visible, sir?
Yes, yes. Okay, Dr. Ramakrishna, we can start. Dr. Asta will join in sometime. Dr. Ramakrishna, we can start recording.
ओके सर, कर रहा हूँ. Okay, sir. Over to you.
Yeah, I welcome everyone for today's session of approach to upper motor neuron syndrome, which is presented by Dr. Dhanya, and Dr. Asta will join in sometime. So, Dr. Dhanya, we can start.
Okay, sir.
Go ahead.
Okay. Today we are going to discuss about the approach to the upper motor neuron syndrome. In this, I'm going to discuss about anatomy, followed by clinical history and examination. First, what is UMN and what is LMN? Above the motor neuron, the UMN or the supranuclear for cranial nerves, it's in the cerebral. It includes cerebral cortex, subcortical structures, cerebellum, brainstem, and spinal cord. At the motor neuron level, it's anterior horn cell for peripheral nerve, and for cranial nerves, it's nuclear level. For motor neurons, below the motor neurons, it's a peripheral nerve. It includes roots, plexus, nerves, neuromuscular junction, muscle. Infranuclear for the cranial nerves. So, upper motor neuron structures in the neuroaxis. Mainly, it includes cerebral cortex, lobes, lobar function. Subcortical structures include basal ganglion, cerebellum, and brainstem. In brainstem, midbrain, pons, medulla, and spinal cord. It includes both ascending tracts and the descending tracts. So, as we already discussed about the cerebral cortex and basal ganglion and thalamus in the previous lectures, I'm going to discuss about the brainstem and spinal cord anatomy mainly. So, going into the brainstem anatomy, the main I'm going to discuss mainly about rule of 4, cross sections, brainstem nuclei, and physiology. So, what is rule of 4? For the any brainstem to remember for us, there are 4 midline structures starting with the M. M, motor nuclei of the cranial nerves. It includes multiples of 3, 4, 6, 12. Medial lemniscus, median longitudinal fasciculus, motor pathways, corticospinal tract. 4S means there are 4 lateral structures which starts with the S. Sensory nuclei of the 5th cranial nerve, spinothalamic tract, spinocerebellar tract, sympathetic tracts. 4 cranial nerves. Each have 4, at the level of medulla, we have 9, 10, 11, 12, 4 cranial nerves. At the level of pons, 5, 6, 7, 8 cranial nerves. And in midbrain and above, 3, 4 optic and olfactory, 4 cranial nerves. So in this picture, we can see midline structures which are starting with M. Motor nuclei, MLF, medial lemnisci, motor pathway, corticospinal tract. Which are present in the lateral part, as we already discussed in the previous one. Spinal nuclei, sensory nuclei, spinothalamic tract, and sympathetic tracts, and spinocerebellar. This is the spinocerebellar tract, which are present on the lateral part side. So 4 cranial nerves, which we told as olfactory, which are present at the above and above the midbrain. Olfactory, optic, and 3rd and 6th cranial nerve, 3rd and 4th cranial nerve, we can see here. In the pons, we have 5 trigeminal nerve, 6th one abducent nerve, 7th facial nerve, and 8th acoustic nerve. In the medulla, 9, 10, 11, 12, glossopharyngeal, vagus, accessory, and we can see the hypoglossal nerve. So these are the structures for rule of 4. So what are the motor nuclei of the brainstem? In the brainstem, we have oculomotor nerve, which is a general somatic efferent, and which is present at the midbrain level of the superior colliculus. Trochlear nerve. It's present at the level of the inferior colliculus, present in the midbrain. This is also general somatic efferent. Abducent, sixth cranial nerve. It is also somatic, general somatic efferent, present in the pons. Next, hypoglossal. This is general somatic efferent, somatic motor. It's present in the medulla, and it's 12th cranial nerve. Next, general visceral efferents. Edinger-Westphal, superior salivatory, inferior salivatory, and dorsal motor nucleus of the vagus. These are all parasympathetic general nerves, which are general visceral efferents. And each present in Edinger-Westphal is present in the midbrain, superior salivatory and inferior salivatory present in the pons, and dorsal motor nucleus of the vagus present in the medulla. Next, special visceral efferents. Brachiomotor, these are trigeminal motor, facial, and ambiguous. These are present, trigeminal and facial present in the pons, and ambiguous present in the medulla. So, sensory nuclei of the brainstem. Sensory nuclei, mainly we know fifth cranial nerve, which include mesencephalic root, principal sensory nuclei of the fifth, and nucleus of the spinal tract of the five. In mesencephalic root is somatic afferent, general somatic afferent, and principal sensory nucleus of fifth cranial nerve is a somatic. This is also general somatic afferent. This is present in the pons, and this helps in the touch and pressure sensation from the head via the cranial nerve 5, and nucleus of the spinal tract of 5. This is also general somatic afferent, present in the pons, extending through the medulla to the upper cervical cord. This carry pain and temperature sensation from the head via cranial nerves 5, 7, 9, and 10. This is also called as trigeminothalamic tract, these two. Next, special visceral afferent. This is nucleus of solitary tract and rostral portion. This is present in the pons, helps in the taste sensation via 7, 9, and 10. Next, visceral afferent. This is nucleus of solitary tract, caudal portion, present in the medulla. And as we know, eighth cranial nerve is a special somatic afferent. Cochlear nuclei helps in hearing. Vestibular nuclei helps in balance and equilibrium. So the tracts present in the brainstem. We have both ascending tracts and descending tracts. So medial lemniscus, which carry the fibers from the nucleus gracilis and cuneatus, and the destination is at VPL nucleus of thalamus. This is a general somatic afferent. Next, lateral spinothalamic tract. This is also a sensory tract which carry from the posterior horn of the spinal cord. This also ends at VPL nucleus of the thalamus. Lateral lemniscus. This carry fibers from the cochlear nuclei to the inferior colliculus. This is special somatic afferent. Next, medial longitude MLF. MLF is this carry fibers from the PPRF and sixth nuclei and vestibular nuclei, which the final destination is at the third nuclei. This crosses just above the sixth nuclei, ascend in the midline in the dorsal tegment. Motor fiber, descending those are ascending fibers in the brainstem. Descending fibers, which we know, are corticobulbar tract, corticospinal tract, rubrospinal tract, medial longitudinal fasciculus, and central tegmentum tract. Corticobulbar and spinal are mainly originate from the motor cortex, and bulbar carry cranial nerves nuclei to the cranial nerve nuclei. Corticospinal carry to the spinal cord. And rubrospinal tract, it originates from the red nuclei and carry to the spinal cord. Medial longitudinal fasciculus, it carry fibers from the reticular formation and vestibular nuclei to the reticular formation and spinal cord. Central tegmental tract also carry fibers from the red nucleus to the inferior olivary nuclei. So at the level of the superior colliculus, midbrain, here we have the cranial nerve, third cranial nerve, and which we can see here, which is exiting out passing via the red nucleus and the substantia nigra. This is substantia nigra, and here we see the corticospinal tracts. These are frontopontine fibers. These are corticobulbar fibers, and parieto-temporopontine fibers. And also we have at the level of midbrain, we can see red nucleus. Beside the red nucleus, dentatorubulo-thalamic tract is there. And beside this is called medial lemniscus, which we just discussed. And lateral spinothalamic, this is lateral spinothalamic tract. And this is medial geniculate body. And here we see the MLF. Next, going into the next cut, pontine cut section. In the pontine cut section, in the mid we can see the motor nuclei, which is fifth cranial nerve, and it has a principal sensory nuclei, and this is motor nuclei of the cranial nerve 5. And here we can see the MLF, and these are medial lemniscus. These are transverse pontine fibers and corticospinal tract. So, this is the fourth ventricle. Above the fourth ventricle, superior cerebellar peduncle is there. This is the cut section of the medulla. Medulla, we can see in the midpoint. These are the pyramidal tracts: medial lemniscus, MLF, and hypoglossal nerve. This is hypoglossal nuclei, cranial nerve 12, and this is the dorsal motor nuclei of the cranial nerve 10. So coming to little lateral side, we can see the inferior olivary tract, and these are the spinal lemniscus. Towards the lateral side, spinal lemniscus, ventral spinocerebellar tract. This is spinal trigeminal nuclei, and this is inferior cerebellar peduncle. Above we can see inferior vestibular nuclei and medial vestibular nuclei. So these are the cut section at the for the three brainstem structures. And blood supply to the brainstem. Mainly here I'm discussing only the posterior circulation. So two vertebral arteries join to form the basilar artery. Basilar artery ends as posterior cerebral artery, and in between it gives the branches posterior inferior cerebellar artery. Vertebral artery itself will give a branch called posterior inferior cerebellar artery, which supplies to the medulla and cerebellum, lower cerebellum. And after going up in the this basilar artery gives anterior inferior cerebellar artery, which gives supply to the lower pons and lower and middle pons and anterior cerebellum. Next, superior cerebellar. This superior cerebellar artery, which supplies the upper pons and lower midbrain and upper cerebellum. Next, posterior cerebral artery. It ends as a posterior cerebral artery. This posterior cerebral artery, medial occipital and temporal, it gives supplies to the medial occipital and temporal cortex and subadjacent to the white matters, and posterior corpus callosum and upper midbrain. From here we get branches, thalamoperforate branches, which supply and thalamogeniculate branches, which supply to the thalamus. So, so this is next. We'll discuss about the anatomy of the spinal cord. So, spinal cord is a downward continuation of the medulla from the upper border of the posterior arch of C1 to the lower L1. So this we should know. I'll be discussing about what is chorda, conus medullaris, chorda equina, and phylum terminal, and we have 31 pairs of spinal nerves. So this is conus medullaris at the end of the spinal cord. And after the fibers after the spinal nerves after leaving the spinal root, and they form a tuft of fibers called phylum terminal. So what are the major tracts present in the spinal cord? We have descending tracts and ascending tracts, and the arrangement. So these are the ascending tracts in the blue, and these are the descending tracts. So these are this is posterior column, which carry, this is gracilis fasciculus and cuneate fasciculus. This carry posterior columns, dorsal column. And on the lateral side, we have spinocerebellar tract. This is posterior spinocerebellar tract. and this is anterior spinocerebellar tract. Below it, spinal olivary tract is there. And here we have the anterolateral part. Anterolateral part includes spinothalamic, spinoreticular, spinomesencephalic, spinotectal, and spinohypothalamic fibers. These are ascending fibers. So descending fibers, main tract is lateral corticospinal tract, and this is anterior corticospinal tract. Along with that, we have fibers which descend from rubrospinal tract from the red nucleus, and this is descending autonomic fibers. These are reticulospinal fibers. These are lateral reticulospinal fibers, and these are medial reticulospinal fibers. Lateral reticulospinal fibers are from medulla, and medial reticulospinal fibers are from pontine. And this is vestibulospinal tract and tectospinal tract. So I'll be discussing each ascending tract separately. So major ascending tracts, as we already told, dorsal column, spinothalamic tract, spinocerebellar tract, and spino-olivary tract. So going into the dorsal column, dorsal column consists of fasciculus gracilis and fasciculus cuneatus. Fasciculus gracilis are fibers from the lumbosacral region, and cuneatus are fibers from the upper cervical region, cervicothoracic regions. So these carry ascending ipsilateral proprioception, vibration, fine touch, and touch pressure sensation. So this dorsal column ascend and synapse at the nucleus of they ascend and synapse at the nucleus of the fasciculus gracilis and nucleus cuneatus, then project the decussating fibers to the medial lemniscus system. Here at the medial lemniscus, the decussation is seen, and it goes up and at the end of the thalamo-parietal radiation ends in the cortex. So what happens if there is a lesion in the dorsal column? This results mainly in the sensory ataxia. So impaired joint position sense, impaired vibration sense, and positive Rombox sign. Also, sensory loss of touch, pressure, and paresthesia also is main reason causing the Lermet's phenomenon, which is seen in subacute combined degeneration, cervical spondylosis, MS, radiation myelopathy, and intramedullary tumors. Next, going into spinothalamic tract. So spinothalamic tract is located in the lateral column of the spinal cord. This carry mainly pain, temperature, root touch sensations. This consists of the contralateral, this is crossing at the level of the spinal cord. Contralateral projection of the second order neurons, which receive afferent inputs from the dorsal root. This is the dorsal root ganglia. These second order neurons are located within the gray matter and of the spinal cord and project via the ventral commissure. Here in the ventral commissure, they are crossing, we can see. To the contralateral side, after ascending one level or more, 1 or 2 levels above they'll cross. And lesion of this spinothalamic tract results in the, as this goes up, and we can have the loss of contralateral loss of pain and temperature and crude touch. So the somatotrophic organization is also equally important, as in the fasciculus gracilis and cuneatus, cervical is placed towards the lateral side, whereas sacral is towards the medial side. Whereas in the spinothalamic tract and lateral spinothalamic tract and corticospinal tract, cervical fibers are placed towards the medial side, and sacral fibers are placed towards the lateral side. So this is one of the reason why when we have an intramedullary lesion, so the fibers which are affecting will be the cortical fibers, as here the lesion will be, which are the fibers affecting will be the cortical fibers. So there will be a sacral sparing. Because of this somatotrophic organization, the sacral sparing will be there in the intramedullary lesions. Next is spinocerebellar tract. Spinocerebellar tract are present located on the lateral white matter of the cord. They carry unconscious proprioception sensation from the spinal cord to the cerebellum, play a major role in the muscle coordination. These are divided into posterior spinocerebellar tract and anterior spinocerebellar tract. Posterior spinocerebellar tract carries gross limb fibers. and these are the posterior. And the anterior spinocerebellar tract carry fine limb movements, which goes into the superior cerebellar peduncle, whereas this posterior spinocerebellar goes into the cerebral cortex via inferior cerebral peduncle. Next tract, ascending tract, which the one of the major tract is spino-olivary tract. Spino-olivary tract neurons carry proprioception information from the tendons and the muscles. The axon will enter the dorsal aspect of the spinal cord and terminate within the dorsal gray matter. From here, they synapse and cross the midline into ascend in the white matter at junction between the ventral and lateral white columns as the spino-olivary tract. They will terminate on the inferior olivary nucleus. From here, there is a further crossing entering into they cross from this side to opposite side and enter into the cerebellum via inferior cerebellar peduncle. Due to this crossover from one side to other and back again, they convey information from the ipsilateral side related to the cutaneous as well as proprioception information. It is involved in the motor learning and coordination by relaying sensory information to the cerebellum. And it connects the spinal cord to the inferior olivary nucleus and subsequently the cerebellum. So any lesions in the spinocerebellar and spino-olivary tract results in the ipsilateral ataxia of the limbs and gait, intentional tremor, dysmetria, so cerebellar signs mainly. And also it is very difficult, as we already read in the spino-olivary tract how it will carry. So it is play a role in difficulty with learning and executing skilled motor movements. So these are the ascending tracts which we just discussed. Next, major descending tracts present in the spinal cord: corticospinal tract, rubrospinal, tectospinal, vestibulospinal, reticulospinal, and descending autonomic fibers. So the major corticospinal tract, this corticospinal tract is a heterogeneous and carries descending input not only from the primary motor cortex but also from the frontal premotor region and the parietal cortex. At the level of the medulla, the majority of the corticospinal tract decussate to form the lateral corticospinal tract, located in the lateral column of the spinal cord, while minority descend without decussating as a ventral corticospinal tract, and this is located in the ventral column. The lateral corticospinal tract synapses with the interneurons and motor neurons in the spinal cord. Although the ventral corticospinal descend uncrossed, the fibers from the ventral corticospinal eventually cross from the ventral commissure, leading to the mostly contralateral connections, particularly to the limb musculature. So lesions in the corticospinal tract at the level of the spinal cord generally results in the ipsilateral paresis, particularly affecting the anti-gravity muscle. So corticospinal tract, if they are affected, the flexor muscle in the legs, the flexor muscles of the legs are involved. And for the arms, extensor muscles of the arms are involved. This is very easy to remember as we see a hemiparesis patient. The attitude of the limbs, what we are seeing is the opposite muscles are weaker. So in the leg, we see patient is extended. So the flexor muscles are weak, like hip flexion, knee flexion, and foot dorsiflexion. In the arms, extensor muscles like deltoid, triceps, and abductors also weak. So deltoid, triceps, wrist extensors, and finger extensors. So there will be an increased tone, increased muscle stretch reflexes, and Babinski signs are present. So just going into the other descending fibers, we know is rubrospinal tract. Rubrospinal tract, this is the rubrospinal tract, which is ending in the red nucleus. From the red nucleus, they cross in the ventral tegmentum, caudal to the red nucleus. They form a rubrospinal tract and ends in the anterior horn of the spinal cord. This facilitates the activity of the flexor muscles. So, in an inhibitory activity to the extensor muscles. So, this helps in the response for the control of the muscle tone and synergy of the movements. So, pyramidal pattern of the spasticity is basically because of the rubrospinal tract. and lateral reticulospinal tract. Lateral reticulospinal tract, as we see here, this forms from the reticular formation, and they also ends in the anterior horn cell of the spinal cord. This facilitates the extensor muscles, especially trunk and proximal muscles of the extremities. Next, medial reticulospinal. This inhibits the whatever above, and plus they inhibits all the muscles, and this is an inhibitory, and autonomic fibers are also inhibited. Next, lateral vestibulospinal and medial vestibulospinal. Lateral vestibulospinal facilitate the anti-gravity muscles, extensors of the trunk and limbs. And medial vestibulospinal tract influences the muscles of the upper neck, upper back, and head. This is main reason we get the vestibulocholic reflex. And tectospinal tract arises from the spine, superior colliculus. Superior colliculus, and they crosses influences the muscles of the upper neck, upper back, and head. Movement of the head in response to the visual stimuli. So till now we discussed the white matter. In the gray matter of the spinal cord, we have 10 lamina. So first one is postromarginal nucleus, second substantia gelatinosa, 3 and 4 nucleus proprius, and 5 and 6 are they are the base of the dorsal column. Next, 7 forms the nucleus dorsalis, Clark's column, and intromediolateral and intromediomedial nuclei of the lateral horn. And 8 and 9, these are the medial and lateral groups of the nuclei of the anterior gray column. And 10 is surrounds the central canal. 10 surrounds the central canal and composed of the gray commissure and substantia gelatinosa centralis. So, sir, I'm done with the anatomy, sir. We'll go into the clinical history perspective. Sir? Okay. I think we'll go into the clinical history. So, going into the clinical history, so what are the symptoms? What UMN syndrome? What are the symptoms we'll be seeing? Negative signs and positive signs. So, patient may have weakness, loss of selective motor control, slow. If they have minimal weakness, it can be present as a slowness and clumsiness, impaired dexterity. And the positive signs which we see are spasticity, hyperreflexia, clonus, Babinski sign will be positive, and flexor spasm, co-contraction, and spastic dystonia. These positive signs are mainly because of loss of dorsal reticulospinal inhibition and unopposed vestibulospinal and medioreticular spinal tract pathways. So, first, once we get to know the symptoms like weakness or loss of selective motor control or slowness or clumsiness, impaired dexterity, first step will be onset and progression. Onset will help us to determine the cause. So whether it's an acute onset, subacute onset, or chronic onset. Once the onset is we know the onset, we have to know about the progression of the weakness, which helps to determine the underlying pathology or ideology. So if onset is hyperacute, so we consider the differential or associated pathology as vascular. So always most commonly it is vascular in hyperacute cause, whether central or peripheral. If it's acute or sudden, so we have to consider vascular demyelination, bleeding. So first consideration will be stroke. Demyelination is also a possibility. Tumors can also present acutely if the bleeding is occurring in the tumor mass. Next, subacute presentation. Subacute presentation, then we will consider infections, vascular cause, demyelination, tumors, metabolic, or nutrition. Infections are usually subacute. Vascular causes can include multi-infarct or recurrent stroke or vascular even the vascular malformations, and like dural AV fistula. In rapidly multiplying malignant tumors tend to present subacutely, and acquired muscle diseases such as in the LMN, basically this is inflammatory myopathy, should be prioritized in adults presenting as subacutely as they are treatable. Next, chronic or gradual. And then we have to consider degenerative, genetic, metabolic, or toxic, or endocrine. So chronic onset suggests it's a degenerative condition. Like example, MND. For genetic disorders, it can be like a genetic myopathy. Or endocrine or metabolic or toxic causes, primary progressive MS can also present chronically. So next, progression. The rate of continuity of the progression also helps to differentiate the etiology. Whether the symptom is suddenly started and improves, this suggests ischemia or demyelination, or it's progressing for a time, then improves. Again, this points towards the ischemia or demyelination. If it is continuously progressing, then it suggests degenerative or genetic causes, or recurrent stroke, or progressive forms of demyelination. So the second step is analyzing the symptomatology, what the patient has given, whether it is pure motor syndrome or also includes sensory motor, and identify whether it is a UMN or LMN. So before knowing going to the identification, we should know what are the differences between the UMN and LMN lesion. In UMN lesion, the tone will be increased, so they will have hypertonia, stiffness, spasticity. And in LMN, the tone is reduced or lost, hypotonia or flyal loose. And the bulk will be relatively preserved in UMN. It's very little atrophy, often due to disuse. And in LMN, atrophy with loss of bulk is prominent. Fasciculation is present in LMN, and movement pattern in a pyramidal pattern, like in upper limb flexors or abductors are involved. In lower limb extensors or adductors are affected. And whereas in LMN, there is more of a focal lesion, a single muscle or a muscle group can be involved. Other clues is they may have loss of dexterity, trip and they, because of the spasticity, they'll trip and fold. Clonus also they can give in the history, and flexor spasms. In the LMN, they'll usually have buckling and falls are the more common, because there will be if they have the proximal dominant weakness. So how to historically establish the UMN lesion. So if the patient is having tone and stiffness, so how they may describe it? The patient may describe the limb feeling, they may describe the limb is feeling like a stiff, like a log, or they may report that the particular limb is not moving, it's having an end block while they're using the limb. And they also tell that they have difficulty bending the joints, such as knees, if they have the spasticity. And the other feature is the like in spasticity, because they may not able to bend, they'll trip while walking, they'll trip and fold, and they may have the falls. And if the patient experiences sudden jerk, we can ask them whether while they're walking or when they kept more pressure, if they are whether they are having a sudden jerky movement. So that can be also helps us, like it can be a clonus, particularly when placing the foot on the floor while climbing. And this is acts as spasticity is a velocity dependent. If the patient may also, we can also ask the history, like if they're walking slowly, they may not feel the stiffness. They may have very little problem, but if they increase the speed or when they're running, they can feel the difference, the stiffness may be increased. So, and weakness pattern and movement, the weakness tend to be regional or segmental, rather than involving a single muscle or muscle group. In LMN, which we see that it's a single muscle or a muscle group is involved. And classical pyramidal pattern of the weakness involves flexors and abductors of the upper limb. And ask about the loss of dexterity or clumsiness. So they may not have the fine, they will not be able to do the fine movements easily. So that there will be some mild clumsiness. And this is an early feature, like compared to the other, like weakness, stiffness, and all. And they may also report in the, as we can see this in the spinal cord lesions, there will be a report flexor spasms, which are sudden involuntary jerking of the lower limb. And although buckling is more common in LMN, UMN also still buckle. And one thing which we can differ is, in especially if extrapyramidal involvement is present, they may result in injuries due to the rather than due to lack of protective reflexes. like falls related to UMN, they will have forehead injuries. Because they won't land themselves on the elbows. Whether if it is an LMN lesion, their protective reflexes are still there. When they fall, they'll have the injuries on the elbows and knees. And other motor, like bulk of the muscle also we can help us. We can ask whether the bulk of the muscle have reduced or preserved. So usually in UMN it is preserved. Well, in LMN we can see the atrophy. We can ask about the fasciculations. They'll be absent usually in the UMN, present in the LMN. And cramps should be asked in the history whether this is a feature of LMN, but spasms are a feature of UMN. So we have to differentiate whether it's a cramp or spasm in the history. And after asking about the motor history, we have to ask other associated features also, which helps to localize the lesion. So for the cranial nerves, basically whether they have the ptosis, drooping of eyelids, and we can ask about the diplopia. If it's a binocular, definitely it's neurological. Unilocular, it most probably it is a non-neurological. And once we know if they have the binocular vision, we have to ask whether it's a horizontal or vertical or combined. And direction of the gaze, whether the diplopia is maximum on one seeing one side. And we have to ask about the difficulty in speaking, slurring of the speech, difficulty swallowing. And human involvement also we can see, like cough, aspirations after swallowing. We have to ask to rule out any cranial nerve history. And it's never complete without asking the bladder history. Bladder symptoms related to UMN involvement is mainly because of the storage dysfunction. The symptoms includes frequency, urgency, precipitancy. In acute spinal cord presentation, they may have the retention of the urine. And in cortical bladder involvement, like orbitofrontal lesions, patient may have lack of concern or having issues with the control of the urinary symptoms. So UMN is spastic or overactive bladder. So urgency, frequency, nocturia, urge incontinence, and difficulty whereas in the spinal cord, they may have difficulty initiating the stream or small volume voids. This is seen when the lesion is cord lesions above the S2 or S4. And one more thing I want to add here is in spinal cord lesion, the bladder symptoms usually will be dyssynergia. UMN bladder is urgency, small volume, hyperreflexic detrusor. Whereas I'm just saying the LMN bladder dysfunction also. It is usually areflexic or flaccid. This is mainly related to the voiding. So overflow incontinence, large residual volume urine will be there. They have to strain to void, loss of bladder sensation, no detrusor contraction. This is seen in conus medullaris lesion, cauda equina syndrome, and peripheral neuropathies and diabetes. This helps in the cauda conus differentiation. So bladder symptomatology, storage dysfunction, or it's a voiding dysfunction. Next, bowel dysfunction. In UMN bowel dysfunction, they may present with constipation, impaired voluntary control, reflex mechanism is intact, so hyperactive sphincter will be there. Incontinence may occur in a very late cases. Whereas LMN bowel dysfunction, they'll have atonic sphincter, loss of perianal reflex, early fecal incontinence. Again, this helps us to differentiate from the cord from the conus injuries. So even the sexual dysfunction, in the UMN dysfunction, they have erectile dysfunction, ejaculatory dysfunction, reduced genital sensation, preserved reflexogenic erections in some cases. So this helps to differentiate from the lower thoracic or cervical cords lesions. So, and autonomic dysreflexia above the T6. So in the upper cervical cord lesions, we can see this. They'll have a complicated high UMN cord sign lesions like severe hypertension, bradycardia, headache, sweating above the lesion, flushing, piloerection, blurred vision. So this can be triggered by bladder distension or bowel impaction or pain. So we have to, so I'm just summarizing the clues from the UMN localization. So if the UMN signs are present and associated symptoms helps us to, if in the cortical involvement, Weakness pattern. Weakness is often concentrated predominantly involving the distal hand and the face. So associated cortical signs also, if they present aphasia, agnosia, or apraxia, cortical visual loss, seizures. So now this localize the lesion to the cortex. If patient have a dense weakness because of all motor fibers are funneled through a small area in the internal capsule, so they'll have dense hemiplegia without any cortical or sensory signs, and this is a very sudden onset. Reflexes are brisk, and this localizes to the subcortex or the internal capsule. And if the to localize, anyway, I'm going to discuss conus coda later again. Just to localize, for conus, mixed UMN and LMN lesion, early bladder and bowel will be there. Perianal sensory loss. This is mainly present in the conus, whereas in cauda, bladder will be later involved, and asymmetric radicular pain and pure LMN lesions will be seen here. So for the brainstem, so the points which helps us to towards the brainstem lesion, localized towards the brainstem, cruciate sign. So it's a crossed hemiplegia in the brainstem. Cranial nerve involvement on one side, and the motor weakness is present on the opposite side. And other one, eye deviation. If the patient experiencing eye deviation upon onset, the brainstem lesions are most likely deviate to the opposite side of the lesion. And cranial nerve symptoms, any cranial nerve symptoms, diplopia, facial weakness, dysphagia, also localizes to the brainstem. And hallmark of the brainstem lesion is crossed findings, ipsilateral cranial nerve and contralateral UMN. A small, easy to memorize. If third and fourth cranial nerve involved and contralateral UMN weakness midbrain, and sixth and seventh, it's contralateral UMN pons. Ninth to 12th, medulla. So vertical localization via cranial nerve involvement is easier. And to localize to the spinal cord, there will be a definite sensory loss. The most common sign which we have, crucial sign is sensory level. And associated symptoms like Lermert sign, girdle sensation, or a band-like sensation. And they may have unusual patterns such as cruciate paralysis, contralateral lower limb, and ipsilateral upper limb, because this suggests the higher cervical cord level. And if LMN findings are present, atrophy or fasciculation, the lesion is localized at or above the highest level. So wherever we see the LMN, above that level only the lesion should be present. And key features are sensory level is most important, UMN signs below the lesion, LMN signs at the level of lesion, early bladder involvement in the spinal cord, and there will be a dyssynergia, and Lermert sign if the cervical cord involvement is there. And an extrapyramidal system, if the weakness involves the extrapyramidal tracts, like they may have rigidity, bradykinesia, and involuntary movements, is also can be seen. So sensory level, so to localize in which cord, so highest height of the cord lesion, whether the UMN is from the cord versus the brain. So thoracic level, sensory level at the thoracic cord, and umbilicus, it is at T10, and lower thoracic at umbilical T10, and just above the umbilicus it's T8, below the umbilicus T12, and nipple level it is T4. Neck band sensation is cervical cord. This helps to rapidly localize the cervical cord lesion. Sir, shall I continue?
Hello, Dr. Dhanya.
Good evening, ma'am.
Hey, good evening. I'm Dr. Astha, moderator for today's session. Okay, so it was a nice presentation. What else have you further?
Ma'am, I have the examination part also, ma'am. Here I've just 2-3 slides for the summarizing to localization, and then we'll go for the examination, ma'am.
Okay, so how many more slides?
I think few more in the examination. I have few videos, ma'am. This is the main end, ma'am. I'll just go for the inspection, tone, power, reflexes, and gait and coordination in the UMN.
Okay, fine. You complete this part first. Then we'll
Okay.
go for discussion.
Okay.
Okay.
So, we'll
Sorry, anyone has anything to discuss as of now? Anyone who wants to ask anything, or shall we continue? You all can unmute your mics and ask if you have any questions or anything you want to discuss. Okay. Okay, I don't think they have any questions as of now. Dr. Dania, you can
Okay.
continue. Okay.
Okay. So, before before going into the examination, I'll just tell the UMN and LMN. The tone will be increased in the UMN, LMN it will be decreased, and bulk will be my. I think I've discussed this already. I'll just go for the next examination. For the UMN examination, any examination, motor examination, inspection, tone, power, reflexes, superficial reflex or plantar reflexes, and gait and coordination. So for the inspection, we have to just observe what is the arm posture. If the in the arm, if it's a UMN lesion, it will be flexed and adducted pattern, and leg posture will be extended and plantar flexed. Gait deviation can be, it will be stiff. Okay, this I'll tell later. And the muscle wasting, we can, if it is, unless it's a chronic or disuse, we may not observe the muscle wasting much, and there will not be any fasciculation seen. And contractures in long-standing patients, we may see the contractures. And inspection often give the diagnosis. We have to see without touching the patient. So next we have to check the tone. UMN tone will be spastic. It's not rigid. The spasticity is velocity dependent. As increases the resistance, more noticeable with the rapid movement, and it's mainly affecting the anti-gravity muscles. There will be a clasp knife phenomenon seen. Basically, initially there will be a severe resistance. At one point, there will be a sudden release of this resistance. That's called clasp knife phenomenon. And UMN, in the UMN features, facial involvement, lower face weakness with preserved emotional expression will be there, and sphincter disturbances may be present. Associated sign loss of arm swing, abnormal mirror movements, and subtle signs. If they have mild weakness like pronator drift and mild tongue deviation can be seen. So to I'll discuss again these later further. Reflexes like hyperreflexia and pathological reflexes, Babinski, Hoffman's will be present. Clonus will be there. Superficial reflexes will be absent. Atrophy is mild in or late in the disuse. Fasciculations are absent. Fine motor and skilled actions are impaired. So this is to check the tone of the upper limbs. First, we are checking at the wrist. And then at the elbow joint, supination, pronation. At the shoulder joint, in both the limbs we have to check. And now we're checking the tone of the lower limbs. At the hip joint, and then now at the knee joint, flexion, extension. At the ankle joint. So this is to This is what we are seeing, the clasp neck phenomenon. So we have to differentiate the spasticity from Gegenhalten paratonia. This is velocity dependent and this is velocity resistant to the passive movements. And pathophysiology, UMN lesion, this is mainly because of the UMN lesion, and the Gegenhalten is seen in the frontal lobe dysfunction. Resistant pattern increases with the faster movement, and we can see this clasp neck phenomenon. And this is inconsistent and non-velocity dependent Gegenhalten. Patient cooperation, patient is unaware in this, involuntary but modulated by attention. Distraction may not cause any change in the spasticity, but in Gegenhalten, this will cause the, often it is reduced. Tone is directionally unidirectional, and this tone is increased in multidirectional. Associated conditions are stroke, MS, and cerebral palsy. And Gegenhalten, it's seen in dementia, encephalopathy, and key clinical finds are clasp neck phenomenon, and resistance fades with distraction in Gegenhalten. So power, human weakness follows a stereotype pattern. Upper limbs, shoulder abductors are reduced, elbow extensors, wrist and finger extensors weakness. In lower limb, hip flexors, knee flexors, and foot dorsiflexors. And the preserved are finger flexors, knee extensors, and plantar flexors. So reflexes are hyperreflexia, and early spread of the reflexes, there will be a crossed adductor reflex, inverted radial reflex if it is the lesion at the C5 or C6, and if it's supranuclear, exaggerated jaw jerk is seen. So next, if the reflexes are exaggerated, we have to check for the clonus. Clonus is a rhythmic, involuntary, repetitive muscle contraction. The types of clonuses we can check in ankle clonus or patellar clonus or wrist clonus. Interpretation is like sustained clonus, highly specific of the human lesion, and unsustained can be appear in the LM, anxiety or hyperthyroidism. This reflects the unchecked spinal oscillatory circuits due to the UMN disinhibition. Here we can see the this is Gegenhalten actually. So here we can see the clonus, ankle clonus. Here we can see the patellar clonus. We have to hold the upper part and then next, going into the superficial reflexes, in abdominal reflex, cremastic reflex will be absent. Anal wing may be reduced. Next, plantar reflex, Bhavinsky sign, upgoing extensor plantar response, and considered as a hallmark for the corticospinal dysfunction. So, Babinski can be mainly done, classical Babinski can be done by lateral, from the lateral sole across the ball. There will be a flexion of the toes, extensor of the great toe with or without fanning. gold standard for the human. Other methods to perform the Babinski are Chaddock, Oppenheim, Gordon, and Schaffer. For Chaddocks, on the lateral malleolus, from the lateral malleolus to the lateral foot, we will be giving a stimulus. The same reflex will be seen. And for Oppenheim, stroke on the anterior anteromedial tibia. And for Gordon, we'll squeeze the calf muscles. Schaffer will squeeze the Achilles tendon. This is mainly next Gonda Allen. Here we do the flex and reflex the fourth toe. There will be an extension of the extensor of the great toe in this. This is a subtle test for the borderline cases. And Throckmorton scratch the dorsum of the foot. This causes the flexion of the toes and extension of the great toe. And Rosolimo tap the ball of the foot or toe. There will be minimal or no movement of the toes and flexion of the toes will be there. Indicates a pyramidal tract lesion. So beyond these, we also have to check the Hoffman's, Tromner, and Wattenberg sign and Roslimo sign, crossed erector reflex, and Georgia. For the Hoffman and Tromner sign, Hoffman sign, flick the distal phalanx of a middle finger. The thumb or the index finger flexion will be there. That is positive. It indicates a human lesion above the C5 or C6 and C6. Tromner sign is tap the olar surface of the distal phalanx. There will be a flexion of the fingers. This is positive, and this is more sensitive than the Hoffman. Use both the signs for the maximal sensitivity in the cervical myelopathy. So I'm just showing the Babinski. So while we are stroking at the lateral border of the hill, and we are going towards the so this is Hoffman's. Here we are flicking the terminal phalanx. We can see the Now we are seeing the Wartenberg sign. This is seen in a UMN sign, UMN lesion. So I think we have already showed Wartenberg's and Rosalimo. Next, other sign is pronata drift. This is very sensitive for the cortical UMN lesion. And finger tapping, slow. It will become very slow when we ask to tap alternative fingers. The finger tapping, it becomes slowed and irregular. And rapid alternative movements also will have pyramidal dysdiadokinesia. Fine motor testing is impaired. So this is pronata drift. We'll ask the patient to hold both the hands, palms facing upwards. There will be a, here in this hand we can see. Next goes in examination. Next thing we have to examine is gait examination. Usually it will be a spastic gait, stiff circumduction. If it's a hemiplegia, they may have hemiparesis. They may have circumduction leg, knee extended throughout, ankle is flexed, plantar flexed, scissoring from the hip adductor overactivity, reduced arm swing. And if they have bilateral lower limb UMN type of lesion, they may have the bilateral spastic gait like scissoring due to the hip adductor hyperactivity, narrow base, and difficulty initiating the steps. So this is a video for the scissoring gait. So next for the spastic gait. And we also can see this spastic ataxic gait, usually seen in cervical myelopathy when there is a cord with the posterior column involvement, or a combined B12 and corticospinal tract disease. Will have a stiff leg movement, poor joint position sense, wide based, and rhombox will be positive in these patients. And also spastic hemiparetic gait was already told. Next, these are flexor spasms seen in the spinal cord lesions. There will be sudden violent, sudden jerky involuntary flexion. So this we already told. This from here it is kind of discussion type. Like, in a spinal cord lesion, we can see in oblique atrophy, oblique myotrophy is seen in Hirayama disease, where there is a cervical spinal cord problem. So we also have to differentiate in the spinal cord lesion. We have to differentiate between the conus and cauda equina syndrome. Conus usually is a sudden and bilateral. Cauda equina is bilateral and gradual and unilateral. Reflexes, knee jerk is preserved and ankle jerks are affected. Both knee jerk and ankle jerk are affected. In radicular pain will be there in the cauda equina syndrome, and lower back pain is present in the conus medullary syndrome. Sensory, there will be a loss of numbness localized to the perianal region, symmetrical and bilateral. There will be asymmetrical perianal numbness in unilateral dermatomal sensory loss in the cauda equina. And motor system, it is symmetric, hyperreflexic distal paresis. It's less marked. And the cauda equina lesions, they'll have asymmetric areflexic paraparesis, more marked atrophy, and sphincter difference, sphincter problem, and are seen early and common. And here they are seen very less common and seen in the late stages in cauda equina. And other things we have to know is for the spinal cord, intramedullary versus extramedullary. Intramedullary is purely localizing, the pain they'll have is purely localized burning funicular pain. In extramedullary, they'll have a prominent radicular pain. In intramedullary, there is a sacral sparing, as I already told, because of the somatotrophic uh, uh, somatotrophic arrangement of the fibers in the spinal cord. There will be a sacral sparing in the intramedullary. In the extramedullary, early sacral sensory loss will be there. And motor signs, corticospinal signs appear later in intramedullary, and extramedullary, early spastic weakness in legs. Progression usually rapid, usually benign lesion will be there. And the extramedullary, the progression will be slow, but the lesion can be a malignant lesion. Ma'am, from here, I'm just gonna discuss I have the slides are basically where is the lesion and what kind of pattern they can present, ma'am. We'll stop here or we'll discuss, ma'am.
Okay, I think we can stop here first.
Okay.
Okay, and how many more slides about this discussion? Hello.
Ma'am, I'm just checking, ma'am. Maybe 10 slides, ma'am. 10 to 15 slides. The spinal cord lesions, and then just localizing, like if it's the cortical, if it's subcortical, and MCA territory, that like that.
Okay, fine. So I think we can discuss now regarding the presentation. You have done well. You have represented all the clinical aspects as well. So that is a nice thing. So first of all, if anyone wants to ask something, or shall I then proceed with the discussion? Okay. So first of all, like you discussed in the beginning, first, it should be very clear that what is UMN versus what is LMN. Okay. So it should be very clear that for your there is for your cranial nerves, what is UMN, and for your spinal cord and other anti-horn cell, what is your UMN. Okay. Now, if you talk about the clinical aspects, can you tell me after all this that what is the first symptom of a UMN syndrome, if I ask you?
Ma'am, they will be clumsy in their work, ma'am. The first initial will be
Yes.
very subtle.
Yes. So that will be the first symptom. Okay. So like you have discussed so many aspects of UMN syndrome. But the first symptom that the patient will come to you initially when he will have some UMN involvement, and the first thing which he'll complain to you will be that there is some clumsiness of fine movements, which may go unnoticed also sometimes. Okay, so that is very important to look for. Okay, and as you discussed that yes, there will be a pattern of weakness, which you can even tell on inspection sometimes that what all can be the cause, whether it's UMN or LMN. Okay, so if I ask you that what is basically mass reflex, can you tell that?
This seen in spinal cord.
Okay,
There will be sudden flexion of I'm not able to tell it properly. Like they'll
no
have the
problem.
bladder bowel incontinence also along with that.
Yeah, so basically, that is a spinal cord. Again, there is a reflex which is seen in spinal cord pathologies. Okay, so in mass reflex, what will happen if there is a severe spinal cord lesion? If you stimulate below the level of lesion, it will produce flexion reflexes of both the lower limbs, and there will be an involuntary voiding of urine.
Mm,
Apart
yes.
from that, there will be hypertension and sweating of the skin below the level of lesion. Okay, so this is also sometimes you can find in your patients, and it can be asked. Okay,
Okay.
then if you have some weakness, how many UMNs, how much percentage of upper motor neurons have to be dysfunction when you start noticing some weakness?
I'm not sure. Maybe 50%, 50 to 60%, no? Ma'am, am I audible? Ma'am, you are,
Hello?
ma'am, you are muted. Ma'am.
Yeah.
50 to
So,
60%, ma'am.
yeah, around 50% whenever, first of all, there'll be weakness. Then, when will you get paralysis?
70%.
And more than
Not sure.
90% are damaged.
More than 90. Okay.
Okay. And when there is a anti-horn cell involvement, so then the weakness will reflect how much? When there is a 70% loss of anti-horn cell function.
Oh, okay.
Okay. So this is how you'll get a clinical presentation. And
Okay.
like you discussed one thing, that atrophy part. Okay.
Yes.
So what will you get in a UMN versus LMN? What difference?
Human, usually there will not be any atrophy, but disuse can cause a mild atrophy. But in LMN, there can be a severe atrophy, ma'am.
Yes. So can you just tell in percentage how much?
Percentage, I'm not sure.
See, usually UMN lesions will not cause more than 20% loss of muscle volume. Okay,
Okay.
whereas anti-horn cell can cause up to 80% of the loss of muscle volume. Okay,
Okay.
so this is what you have to keep in mind, that how much is their trophy, because you may have to, even like you cannot quantify, you have to subjectively tell, okay, that
Okay.
about this much loss is there or not, and so on, and then you can assess that. So if I broadly ask you about UMN versus LMN, what all you have understood regarding the gross differences in a UMN versus LMN pathology, so what all can you enumerate?
Ma'am, tone spasticity.
Okay, so like you
Here
told,
tone will be increased and here it will be reduced. Bulk, there will be a mild atrophy, there will be more atrophy.
no, see
Reflexes,
again,
ma'am,
whenever
here it is.
yes, this is what I wanted to emphasize. Whenever you're telling this, then always tell in LMN it can be normal also.
Okay, ma'am. Okay.
Okay, so you have to, whenever, this is a very important thing, because you have to have the clinical aspect in your mind. Whenever examiner is going to ask you a question, if you're going to say it's increased in this and decreased in this, so where will be the normal tone go? Okay, so even a LMN lesion can present with a normal tone.
Normal tone. Yes, ma'am.
Okay, so these things, these are the subtle things in your answers that you have to be careful about whenever you are answering. So that tells that yes, you are clinically sound, that even if you're getting a normal tone, it can be a LMN
Element.
patient.
Yes, ma'am.
Okay,
Is it in NMJ, ma'am, where we can see the element normal tone?
no, in all of them,
All
even
of
in
them.
a
Okay.
myopathy patient, yes.
Okay. Okay.
Even in a myopathy patient, you can get, whether it's a neuropathy patient, myopathy, what all elements lesions are there, you can get a normal tone. It's in fact, where else can you get a hypotonia? In cerebellar lesions, what do you
Oh,
expect?
yes. Yes, ma'am. There will be a hypotonia
Okay,
in cerebellum.
so
Yes, ma'am.
that, yes, so that you, all those things you have to keep in your mind whenever you are making a differential diagnosis.
Yes,
A
ma'am.
normal tone does not mean that it can't be a lemon lesion. Okay, so similarly, a decreased tone cannot rule out a UMN lesion. Why?
You even in the spinal shock, there will be a hypotonia. Even the cerebellar, they can be a hypotonia.
Okay,
Initially, they may not develop the increased tone immediately.
right. Okay, so that you should keep in your mind. So if you're getting any patient with hypotonia, that is not the only thing that yes, this is a element thing. So you have to tell in the context.
Okay.
So never in the, whenever you is asked the differences, you don't categorize it. Yes, UMN it will be hyper always. Yes, that is a commonly, it will be increased. Tone will be increased. So that is what you can tell. But you have to have that concept in your mind that you can have a hypo even in a UMN lesion.
Okay.
Okay. Then what all are the patterns of weakness like you discussed? about the pattern of weakness in UMN lesion, that you will get a upper limb typical pattern, anti-gravity muscles will be affected. But what
Yes,
else are the other patterns of UMN weakness that you can get?
uh, upper limb and face can be involved, ma'am,
Right.
In
So
the
that is facial pattern.
facial pattern.
Okay,
And
what else?
actually, there are few things like which can look like a peripheral, like hand knob sign in the hand knob region. If they have, we can just have the wrist weakness.
Okay, what else? What all are the other patterns? Because you don't have to have that concept in your mind that a hemiparesis is what is UMN thing. Okay, so you should always discuss all the patterns of weakness that can occur in a UMN patient. So what
This
all you have
can we
discussed, you
say
have to apply that
cruciate, ma'am?
clinically.
For the
Yes.
brainstem, they will have the crossed hemiplegia, like ipsilateral cranial nerve and contralateral limb weakness.
Okay. What else?
And this, if at upper cervical, if they have, we can have the ipsilateral upper limb and contralateral lower limb weakness can be there, ma'am.
No, higher cervical cord, why will be there?
Cruciate hemiplegia because
Okay, fine.
they'll have the crossing of the lower limb fibers is first, later the upper limb fibers will be crossed if the lesion
Okay.
is
What else?
uh,
See, you will have to have in a very clear words, you should always say that it could be hemiparesis, quadriparesis, okay, paraparesis, monoparesis,
paralysis. Yes, ma'am.
facial all these patterns can be UMN.
Okay.
Okay, so you have to be very clear in your answers so that you can say that yes, your concept is clear.
Okay.
Okay. Then what about the superficial reflexes?
Usually absent, ma'am.
Okay, decreased or absent.
Decreased or absent.
Okay, and what happens in the lesion to the superficial reflexes?
Oh, they are present, ma'am, in 11.
Yes, they are normal.
Normally present.
Yes. Okay. Now, can you tell about the origin of the pyramidal tract? From which areas do they get originated?
From the motor cortex, from the fourth layer, from the bed cells, it is originated, ma'am.
Only from there, or it's something
Uh,
different?
Actually, it's from the motor cortex and premotor cortex also. It is originated, ma'am, not only from this.
What is the exact origin? You have to tell the percentage also. How many fibers from where they're originating? This should be very clear in your mind because corticospinal tract doesn't mean only from the cortex.
In fact,
Okay.
I remember it as like very less percentage from the bed cells. It is produced. It is started. Uh,
Yes. Anyone else who wants to take this question? You can unmute your mics and answer if you want.
One third from uh, some motor area, four each from 4 and 6 each area, one third, ma'am. One third from the somatosensory area, 312.
Yeah, very good. So this is how you can tell about the origin. Okay, so it should be very clear. The one third are originating from the cortex, that is area 4. The one third are originating from the secondary motor cortex, that is area 6. And
yes.
one third are originating from the parietal lobe, that is area 3, 1,
Okay.
and 2. Okay,
Okay.
so this is an important thing. Then how many fibers of that are myelinated and unmyelinated? Anyone? See, around 70% of those fibers are myelinated.
Okay.
Okay. And Dr. Dhanya, can you tell about the where the lateral corticospinal tract extends to?
Lateral corticospinal tract. No? Uh, till
Anyone who wants to unmute their mic and answer?
From the cortex, then corona radiata, internal capsule, middle one-third of the cerebral peduncle, then pontine nuclei, pyramids in lateral white column of the spinal cord.
Right.
Late for the lateral mark. For
Till
the
when?
an-
That is I'm asking. No,
ma'am,
till where? Till when it is extending? Till where?
till lateral column of the spinal cord and
Okay. And till where is the anterior CST extending?
till anterior white column of the spinal cord, ma'am.
No, I'm asking in the spinal cord till where?
Level
See, yeah, level I'm asking.
L1 level, ma'am.
Yeah, the lateral one is still the lowest segment. Okay.
L1.
Okay.
Okay,
And
ma'am.
till where is the anterior one? Anyone who wants to take this answer? Okay. So basically that is till the mid-thoracic levels. Okay. So this also you should be aware that the anterior corticospinal tract is ending at the mid-thoracic level.
Okay.
Okay. And how many are getting crossed at the level of medulla?
At uh, lateral corticospinal tract will be crossed at the level of medulla, but the anterior corticospinal tract, once they come down, then then they will cross at the from the ventral commissure and reach to the contralateral connection. So this is up
Yeah, but
to
how many are
75 to 90% will be crossed, ma'am, at the medulla.
right? Okay, so there are 75 to 90% which will be crossed. Okay, can you tell in which disease will you get inverted V sign or rabbit ear sign?
Posterior column involvement, it's seen in B12 deficiency, subacute combined degeneration.
And especially that sign is seen in which type of SSCD?
Subacute combines in which type, ma'am?
Uh, there's something which can induce this SSCD apart from the B12. What else can induce
Copper,
SSCD?
N2O,
Right,
nitrous
right.
nitrous
Yeah,
oxide.
very good. Okay, so nitrous oxide can also lead to this. And in that, in an MRE, you'll get an inverted V sign or rabbit ear sign. Okay. So can
Okay.
you tell what is funicular pain?
It, it's mainly like this ascending spinal tract when if there is a irritation, like for the posterior column, they'll have this pain, ma'am. Like, and
What else? What type is there?
it's
Like when will you say that?
it's a deep ill localized pain, ma'am. It's like uh, not a dermatomal pain. Like
Okay. See, it is usually a central pain or a funicular pain, which is a deep burning or lancinating type. Okay, and it will usually occur in an area of decreased or absent sensation. And it is usually a diffuse type of pain below the level of spinal cord lesion. So it will not have a very good localizing value. Okay,
okay,
so it can be either due to posterior column dysfunction and sometimes in intramedullary spinal cord tumors, you can get that.
okay, ma'am.
So these can be the presentations. A patient can have a radicular or girdle type of pain, or a localized pain, or a central pain or funicular pain. So such patients with UMN lesions, they can come with such pains. Okay. If I talk about the etiology, the common causes of paraparesis, it's known as 4 T's. Can you tell those 4 T's?
Trauma, humor,
Yes.
uh, trauma, humor, TB,
Right.
transverse myelitis.
Right. Can you tell what an inverted reflex is?
It's when there is a lesion at the level, at the reflex center, like element lesion at the reflex center with intact human pathway, they'll have expected reflex is absent, but opposite reflex, there will be an antagonist muscle reflex will be brisk. For example, when we are doing the supinator reflex, we expect the normal is to brachioradialis contraction. Instead, we'll have a finger flexion due to the overflow into the finger flexure pathway. Like if it is the lesion is at the C5, C6.
Okay. What else?
Basically, at the level, the reflex pathway is damaged, ma'am. But
Yeah.
the descending tract will cause this excitability in the lower segments.
Right. So you can, in a simple way, you can understand that when there's a radiculomyelopathy,
Yes, ma'am.
okay, so there is a root involvement and a spinal cord involvement as well. So that root is not going to let that reflex to happen. Okay.
Mm.
But that upper motor neuron which is there, it will lead to the inverted contraction of the opposite muscle.
Okay.
Okay, so what is expected? So you'll get an inverted reflex, whether it's inverted biceps or triceps, and so on. So this is what you should remember, and this is also one of the important aspects whenever you're discussing about the spinal cord
Fine,
pathologies.
sir. Yes, ma'am.
Okay, then SSCD is a very important clinical thing that you should always remember, and you can get cases of SSCDs also. So, in basically, what can you tell? What is a classical presentation of SSCD?
Dissociative sensory loss, ma'am. They'll have this posterior column involvement, but spinothalamic tract is intact. So,
Okay, but is that known as dissociative? Do
no,
we
ma'am.
use that term for that?
No, no, no,
So don't use those terms for this. Basically, it's a myelopathy with brisk knee
no.
reflex and
Yes,
extensor plantar.
okay, ma'am.
Okay, so there'll be an absent ankle jerk, but your knee jerk will be brisk.
Yes, ma'am.
Okay, so this is a classical thing. In your examination, also, you'll get such patients, and you have to be very clear. So, whenever you'll be asked points in favor and against SSCD, so you should be able to tell this because there'll be signs of neuropathy like absent ankle jerk. There'll
Yes,
be a
ma'am.
loss of peripheral sensation like loss of joint position sense and so on. But your knee jerk will be brisk and you'll get an extensor plantar.
Okay.
Okay, so this is a very important sign. And as we discussed earlier, there'll be a rabbit ear inverted V sign in the thing, in the MRI. Okay, and what is the test, the blood test that you can get done in such patients? More specifically,
Vitamin B12, copper.
no, for
Uh,
this SSCD, for which is vitamin
uh,
B12 deficiency induced, what is the most sensitive and specific test for this?
Methyl
methyl
malonic acid.
and homocysteine.
No. See, basically, it is the serum holotranscobalamin 2 level.
Okay.
Okay, so that is one of the tests that you can get done. Okay. And one thing that will be asked is again, one more is spastic paraplegia, that is letharism. So now it's
Yes.
very rare to see, but in exams you can be asked this because in SSCD and these other common differentials that you should be knowing whenever you are getting a spastic paraplegia patient. Okay.
Okay.
So what is the neurotoxin? Anyone who can answer that?
Beta oxalyl amino acid.
Yes, good. So
Done.
it is a beta N-oxalyl amino L-alanine. Okay. So
Okay.
that is one of the things that you should remember whenever you get a case of paraplegia. Okay.
Okay.
Yes. So now talking about anything else which you want to discuss, or shall I discuss further? Any questions? See, one thing that I wanted to tell was about the spasticity part that you told. What do you mean by what do you mean by velocity dependent?
when uh, when we are doing basically this when we are trying to do slowly, there may not be resistance, ma'am. uh, when we are trying to like increase with the speed of the stretch, when it is
Yes.
performed slowly, the tone may be relatively normal, but if it is done more quickly, there will be a resistance. It's mainly because of the velocity sensitivity of 1A afferents present in the muscle fibers, ma'am. And
Okay, right.
spasticity also is it is dynamic and length dependent, and the selectivity is there, as we told for the muscles.
Right. And you discussed about the clonus. Okay, so
Yes,
can you
ma'am.
tell what is sustained versus ill-sustained clonus?
But, uh,
Anyone who can tell? Anyone who can unmute their mics and tell what is ill-sustained versus sustained? Anyone who wants to answer that? Okay, so basically when there are more than five oscillations, then you consider it as sustained. Uh, though there are some places where it is written more than 10 oscillations also. So it is a bit debatable about that. But so you can check which one do you want to follow. Okay, but that is one of the things that is usually considered. And can you tell another thing where apart from UMN syndrome where you can get ankle clonus? Any other thing that you can remember? Anyone?
Hyperthyroidism.
No. Hypothyroidism, there'll be an absent or decreased ankle reflex. You don't get ankle clonus there. I think Dr. Savan, I think, has answered in the chat. Yes, that is right. Serotonin syndrome. Okay. So there also you can get an ankle clonus.
Yes.
So my main aim of telling you all these things is that you have had a comprehensive thing, a presentation. And so how you have to apply that in your exam is the main concern. Okay, you should know that.
Yes,
Okay,
ma'am.
so because in your exam it will not be yes, this okay, this is clear. This you'll always be expected to discuss differentials about every
Yes,
sign that you're going to get. Okay,
yes,
every
ma'am.
symptom and sign will be expected that you'll discuss that in details. So it should be crystal clear about each and every pathology and presentation. Okay.
Yes, ma'am.
Can you tell what are the phases of spinal shock?
Uh, I have that slide discussed. Mainly the we have four phases, ma'am. Immediate from 0 to 24 hours, there will be areflexia and flaccid paralysis. And from early 1 to 3 days, return of some reflexes will be there. First reflex, I think the anal reflex is the one will come back first. And then Babinski may appear early in the elderly. Next stage is intermediate from 4th day to 30 days. Reflex reappears in a predictable sequence. And later stages from 1 to 12 months, spastic hyperreflexia with sustained clonus. So initially we may think as a element lesion because of areflexia and flaccid paralysis first 24 hours.
Yeah, in the return of reflexes, the most common reflex that appears first is what? Anyone?
Bulbocavernous reflexum. Like,
Yeah, no, see in the ankle jerk. Okay. In the third phase, usually there is a reappearance of the DTRs and ankle jerk followed by knee jerk followed by Babinski and then the cutaneous reflexes.
okay.
Okay, they return first. So that is what you should remember whenever there is a recovery. What is autonomic dysreflexia? Can you tell?
When there is a lesion above the T6 in the spinal cord, they will have this. Any small noxious stimulus can have a high sympathetic outflow, like they'll have tachycardia and sweating, all.
Here, this is tricky. So what you should remember is that there's an impairment of the autonomic control. And above the lesion, there is a parasympathetic overactivity, whereas below the lesion, there'll be a sympathetic overactivity.
Yes, ma'am.
Hello.
Ma'am, you are muted, ma'am.
Are you able to hear?
Yes, ma'am.
Okay, so basically there are two things. Parasympathetic overactivity is there above the lesion, and sympathetic overactivity is below the lesion.
Okay, ma'am.
Okay, so if you remember this concept, you'll be able to tell what is happening. So due to the unopposed parasympathetic response above the lesion, above T6, what will happen? The patient will have hypertension, bradycardia, flushing, sweating above the level of injury, and there'll be a pupillary constriction. Whereas
ma'am.
below the level of injury, what will happen? There'll be a pale, cool skin, piloerection will be there. Okay. So when will you trigger this? Like whenever there is any noxious stimulation below the segmental level of injury, like bladder distension, if there is there, rectal fissure, UTI, all these. But there can be some complications also due to this autonomic dysreflexia, like myocardial infarction, seizures, and so on.
Yes.
Okay. Yes. So this is an important concept also which you should remember. Okay, and then you will be also expected that you tell the segmental pointer muscles. Okay, whenever localization will be expected in that pattern, then you should also know those things. Okay, for example, like C5, 3, 4 is a diaphragm. Okay, then C5 is deltoid or arm abduction. In
Yes,
that
ma'am.
way, also you should be very clear because whenever you'll have to differentiate UMN versus LMN, you have to tell whether it's anti-gravity type of involvement or a segmental pointer which is involved and so on. Okay, because at the level of the at the level there will be a element type of lesion.
Element type of deletion
Okay,
and
so in a UMN also you'll have to categorize. Okay, at this if it is a C5 level where you were doing that, then you will have to tell that yes, at the C5 level there is a element type of which you'll have to tell clinically. Okay, so you should know the segmental pointer muscles also.
okay.
So that you can tell yes, at this level these are the element signs that I'm getting, and above this level these are the signs that are favoring a UMN lesion. Okay. So I think blood supply also you should be aware. I think that is that was not discussed probably in the presentation. Okay.
Yes, ma'am. I've discussed only the posterior circulation, ma'am. Spinal cord, I think I forgot to
Yes.
keep initially. I kept in the later slides, ma'am. Spinal cord blood supply.
Okay. Okay. No issues. So basically that also is important because like if you have the spinal cord syndromes and the vascular syndromes, whether it's
Yes, ma'am.
anti-spinal cord syndrome and
Anti-spinal.
so on. So you should be aware that there are two posterior spinal arteries, one anti-spinal artery,
Yes,
and
ma'am.
how they if they're affected. So like if you have anti-spinal cord syndrome or vascular cause, so you can tell that based on
Yes,
the
ma'am.
clinical presentation. Okay. So I think today from the UMN part that we have learned, you should first understand the basic concepts that yes, first you are dealing with a UMN lesion that will be decided by all the symptoms that we have discussed today versus the signs. So that is what your thing to be done, that you have to elicit all the symptoms and signs that will help in differentiating UMN versus LMN.
Yes, ma'am.
Okay. Anything that you feel that you want to ask, or anyone else who wants to ask anything? If not, then we can close this session, sir, or if anything you want to discuss. Shailesh, sir?
Yeah, we can conclude. It was a very extensively discussed presentation. Thank you, Dr. Asta, for moderating this session. And thank you, Dr. Dhamya. There is one more below last question we can take. Below knee amputation, how to check plantar?
Dr. Dhanya, do you want to take this? Like you discussed, like Dr. Dhanya has discussed, you can go back to the slide. Okay, apart from the plantar reflex, there are other methods also. Can you go back to that slide?
Yes. You can check for this Wattenberg.
Yes, one is that.
For the Hoffman and Hoffman, and we can check for the upper limb equivalence, Hoffman and Wattenberg.
Yes,
And
yes, they are
this,
basically considered. Yes. Anything else?
There is one tensor facial lata that we have to palpate. You have to stroke the stump of the amputate limb, and you have to
check
palpate whether tensor facial lata is getting pains or not. That is the method. Okay. Okay, then we can conclude the session. Thank you, Dr. Asta and Dhamya, for nice presentation. And on the last minute, Dr. Asta has agreed for moderating. Thank you very much. We will conclude. Thank you.
Thank you, ma'am.
Okay, thank you, everyone.